Assalamualaikum and good day everyone. Welcome back your week 8 of the lecture. So for this week, we're gonna discuss on the pharmacokinetics. Here is the learning outcome for this lecture. So I divided this lecture into 3 videos. The first video, you need to be able to define the bioavailability as well as the volume of distribution. And your second video, you should be able to define the clearance and as well the elimination rate half-life. So the last video, you should be able to define and interpret the steady state concentration, which are important, which they require you to apply the minimum effective concentration as well as the drug toxicities. And as well as the last video, you should be able to calculate the loading and maintenance dose. Alright, let's recap back what you have learned in your previous 6 weeks of the lecture. So you have learned on the absorptions by Associate Professor Dr. Hanish as well as the distribution and excretions. You also be taught about the metabolism, which is being taught by Professor Dr. Telake. And then these are all about the pharmacokinetics, the principle of ADME. So in this week lecture, I will emphasize more on the drug bioavailability, volume of distributions, half-life, as well as the clearance before you need to know how to calculate the loading dose as well as the maintenance dose. So please have a clear idea about these 4 terms first before you able to use all these informations to calculate the maintenance dose as well as the loading dose. Alright, the bioavailability is the fractions of drug reaching the systemic circulations in the unchanged form. So I would like to highlight here, there are 2 keywords, which are the systemic circulation as well as the unchanged form. So drugs that can be administered either through subcutaneous, through respirations, intravenous route, intramuscular injection, as well as the oral routes, the most common one. So all these drugs require them to have go through the veins, the blue color here, before they can reach to the heart and ultimately reaching the systemic circulation to exert the pharmacological actions. So I would like to emphasize here again, not all the oral drugs are able to reach the systemic circulations except drugs that are given through intravenous injections. Okay, we took one example, oral drugs, either in tablet or syrup formulations. A part of it might not be absorbed at all. Some of them might be being metabolized via the liver or other tissues to the active or inactive metabolites. So the reason why we bother the drugs need to reach the systemic circulation is that in most cases, the drugs that reach the systemic circulations is going to be directly proportional to amount of drug reached to the target organ, which can then exert the therapeutic effects. And that is why they're important to look out the clinical effect of the drugs. You need to know the bioavailability of the drugs. So the bioavailability can be presented as F. Alright, so since I have mentioned before, the intravenous route are directly subjected the drugs to the veins of the patients, we can say that the bioavailability of the intravenous route to be 100%, or the other words, we equal to 1. Usually, the bioavailability in fractions from range from 0 can be up to 1. So the bioavailability can be calculated using these equations. As example, when 100 mg of drug X being administered orally, only 75 mg can be absorbed through the intestine and remaining 50 mg pass the first pass metabolism and available in your systemic circulation. So when we're using these equations, we can calculate that this drug has a 50% of bioavailability, or known as 0.5. So when we talk about the bioavailability, you need to know on the area under curve, or AUC. So let's look at this chart here. You need to know the concentration time graph to know exactly the bioavailability of each drug. The left chart here represents the bioavailability of drugs that administered intravenously. Meanwhile, in the right graph here, represent the bioavailability of the oral routes. So this shaded area represent the area under curve. So please take note that area under curve represent to bioavailability of the drugs. So for oral drugs, they need some time to reach the concentration maximum or Cmax that are available in the systemic circulations. So as you can see that the Cmax of oral drugs is much lower compared to the IV route. It is due to not all the drugs can be absorbed. Besides, some of them are being metabolized by either hepatic or intestine or any metabolizing enzyme that presents in the other organs or tissues. So Tmax represent the time taken to achieve the maximum concentration of the drugs. So one of the reasons why you need to know the bioavailability is due to the bioequivalent study. Who knows, one day, some of you might open up a pharmaceutical industry or work with the National Pharmacy Regulatory Agency, or known as NPRA. As example, you are able to produce your own paracetamol tablet and name the brand as Panadol. So they will do the bioequivalent study to look up whether your paracetamol drugs are equivalent to the other non paracetamol in the market. So NPRA as authorities in Malaysia who are want to make sure that your Panadol complying the effect with the other well-known drugs. So they will calculate all bioavailability of all the drugs and see whether it is matched. That's why we call it bioequivalent, where the bioavailability are matching. You just have to make sure that their bioavailability are same as the original brand Panadol as example. Let's continue on the volume of distribution before you have a short break. So volume of distribution can be defined as volume occupied by the total amount of drugs in the body relative to its plasma concentration as shown in these equations. From this equation, you can predict that drugs that have high volume of distributions have much higher concentration in the extracellular fluid or in the intracellular fluid as compared in the vascular compartment. On the other hand, drugs that are completely retained within this vascular compartment will have a small volume of distributions. So here is the table with characteristic of drugs that cause relatively higher and lower distributions. The most common factors is the drug's lipid solubility and drug ionization at physiological pH. A most lipid soluble drugs, a more lipid soluble drugs and non-charged drugs are able to be absorbed into adipose tissue. This will cause decrease in drug in the plasma concentrations. So drugs that are bound to the tissue protein binding sites will exert either therapeutic effects or the adverse effects. Drugs that has lower volume of distributions are tend to bind to plasma protein, while higher volume of distributions tends to bind to the tissue of the proteins. As I mentioned before, drugs may distribute into plasma or any of these compartments, which drug definitely will be in the plasma and can be distributed to the interstitial fluid as well as the intracellular fluid. So our total body fluid is estimated about 42 liter, which 4 liter consists in the plasma, 10 liter in the interstitial fluid, and remaining 28 liter in the intracellular fluids. So as example, 100 microgram of drug X being administered intravenously. So after a while, the nurse will take some blood samples and they'll do the analysis, which found out that 4 microgram concentration of 4 microgram per liter of drug X available in the plasma. So when using the volume of distribution equation here, So 100 microgram that be administered intravenously, which are the drugs that are available in our body, divided by the 4 microgram per liter, which is the concentration of the drugs that are available in the plasma. And you can calculate it about 25 liter, which shows that this drug S has higher volume of distributions, which means they're not only available in the plasma but can be distributed up to the intracellular fluid.